morning. Okay. So my presentation today is a follow-up to what I presented last year as to the initiative we currently carrying out towards empowering pharmacists at community level to be able to counsel, conduct HIV testing, as well as initiate clients on either PrEP or PEP as per the indications. Next slide. Next slide, please. So the background to this is premised on the fact that currently, as most of these HIV services are being offered within public facilities in a comprehensive care clinic, where, because most of the clients who are seeking HIV prevention services might not be HIV positive, there is a stigma which is associated with being seen to access those CCCs. Also, we know that most of these comprehensive care centers are not well distributed, and some have inconvenient opening hours, which creates a challenge for those clients who have to either walk long distances or incur transportation costs to access those few locations. We also have negative client experiences where, due probably to workload, those settings exhibit unpredictable waiting times due to issues of understaffing and probably limited privacy. Next slide, please. So, within the Kenya National Framework for Implementation of Pre-Exposure Prophylaxis, pharmacies were identified as one of the feasible models where we could extend the provision of HIV prevention services. However, the implementation of this has not really taken off as fast as it was anticipated, because these guidelines were developed in the year 2017, but the rollout into the community pharmacies has not been that fast. So this has created opportunities to then look at what evidence can we provide to the policymakers or to the national HIV program that it is actually possible to integrate the provision of pre-exposure prophylaxis within these service delivery models, riding alongside what has even recently been shown with family planning services. So if a community pharmacy setting can be a platform for offering FP, then why not integrate as well the provision of HIV prevention? Next slide. So in this work, it's more or less an implementational science approach. We hypothesize that if pharmacies are well trained and supported, they are capable of safely initiating and managing most of the clients who are able to be initiated onto either PrEP and PEP. And if given a choice, some of the clients, we are not saying we are redirecting the flow of clients who currently go to public facilities or private facilities. Those clients who might opt to make a community pharmacy their access points for these services can then be able to do that and probably experience less stigma, be able to access these services knowing that some of the outlets open late hours, and also because of the setup, it could be much faster to offer the services. Next. So we were looking at, for these settings, that the pharmacy, when made available at these private pharmacies, how many clients are able to initiate PrEP there or PEP, and who actually initiates, how many continue to be on PrEP, and how acceptable is this model to both the clients as well as the providers, and what is the feasibility of this model in terms of national rollout. Next. So in this model, then we had a standardized checklist where the providers were trained to screen for both PEP and PrEP eligibility using a risk assessment checklist. And if any of these conditions are ticked as yes, then it is possible for clients to be able to be prescribed and dispensed with PrEP. But because this was also a research setup, we were able to provide a remote clinician just to see whether any backup support can be availed to the pharmacy providers. So the study ran from last year, Feb, to July. That's a period of 6 months. We had 12 pharmacies involved within 2 counties in Kisumu and Kiambu. And the services which were availed were both oral PrEP as well as PEP. The eligibility criteria was any adults aged 18 years and above. And for HIV testing, we utilized the provider-assisted blood-based HIV self-testing kit. The services were availed at no fee to the client. Next slide. For the products, we were able to access through a collaboration with the Ministry of Health. Each of those pharmacies were linked to a public facility for their PrEP and PEP commodities. However, the requirement was they still had to make the required monthly reports to the ministry for resupply. Next slide. Next. Okay, just go back a bit. Okay, so what are the kind of clients who were able to access the services at these settings? So there was an uptake of about 684 clients onto PrEP and 173 who were initiated onto PEP. As you can see, the majority were mainly men. However, the clients who are 25 years and below were about 319, which made about 48%. And the majority of them were also unmarried. In terms of risk behaviors, which were self-reported, majority of those reported inconsistent condom use, and the list was among partners living with HIV. These are the serodiscordant couples. Next. So for this pilot extension, compared to what had earlier been done in the original pilot study, there was increased PrEP uptake. There were more clients who were able to uptake PEP. And then the first month or month 1 PrEP continuation was also observed to be much higher, that is at 73%. But also, there was what we refer to as PEP to PrEP transition. And this is a scenario where clients who initially present themselves as PEP clients, with time, because they are frequent PEP users, they were able to be switched over to PrEP. And in terms of whether the clients liked getting their services from the pharmacy, 100% of the providers said they did. And also whether they thought delivering PrEP or PEP services at the pharmacy was difficult. Of course, majority of them said it was not. Next. So a few, next please. Next. Yeah, So in terms of some of the provider and client perspectives, some of them were able to indicate that the pharmacy was convenient for them because it was closer to where they lived and there's some privacy assured. A female participant noted that it was easier also to get their PrEP than in a pharmacy than in a hospital. And some of the providers said that they liked the idea of offering PrEP and PEP services, that they were able to do it and be able to reach more clients. And that the clients were also open in terms of asking for these services, and it was easier for the providers to deliver PrEP services. Next slide. So what do we see as next steps from here? So far, the feasibility looks promising in terms of providing these services within these delivery channels. And they could also be an additional efforts towards sustaining the HIV response in Kenya. We also know that there is a lot of research probably needed as well to assess the model effectiveness. And this is why we intend to now carry out a more robust implementational research so that we are able to probably convince the stakeholders that it is possible to provide these services within this setting. And this will be done through, next, it will be done through a cluster randomized control trial, where in this case we shall also have a control arm. Remember the studies which we have done previously were mainly feasibility studies, and we didn't have a clear way of measuring whether the uptake of these services within those private pharmacies was significant. So we shall have, first of all, more points of services. So we are going to move from the previous 12 sites to 60, and from 2 counties to 4 counties. And that is Kisumu, Homa Bay, Kiambu, and Nairobi. Next. So this will be a 4-arm study where the 60 pharmacies will be randomized to each of those 4 arms. However, the arms 1 to 3 will be the interventional arms, while arm 4 will be the control arm. The services will be provided for free in all the arms except arm 1, where the client will be required to pay the pharmacy directly. For arms 2, 3, and 4, the clients will access these services at no fee, a small token to the pharmacy providers. Next. So we shall measure the 3 interventional arms to the arm 4. And of course, as you can see, for arms 1, 2, 3, it is the pharmacist who will be taking lead in terms of doing the HIV counseling testing and also initiating clients onto PrEP or PEP. However, for arms 3, we are going to station a HTS counselor so as then to assess what is the implication of that. So next and last slide is, of course, we are doing this work in collaboration with the National AIDS and STIs Control Program, that is NASCOP, and the other research partners, that is JQuat. We also have a team from Fred Hatch, and this study is being funded through the Gates Foundation.